Hello, so this is our presentation on the treatments for borderline personality disorder. I'm Mackenzie Hill, and then Sierra Parker will be presenting the second half of the presentation. So just a quick general description. Borderline personality disorder is characterized as a set of symptoms that include impulsivity, struggles in interpersonal relationships, self-harm, feelings of emptiness, and overall risky behaviors. So people with this diagnosis tend to have higher rates of suicidal ideation. BPD also has a high comorbidity rate with PTSD and other anxiety and depression disorders. Some of the causes include childhood trauma, including physical, sexual, and verbal abuse. So, kind of accounting for the comorbidities such as PTSD. And then also from neglect, early parental separation. Those are known to be the most significant risk factors. And that's kind of also a lot of the things we see on the ACEs. So it all makes sense a little bit. And then biologically, BPD has been linked to the limbic systems of the brain and the amygdala, which are the areas that control emotion regulation and specifically rage, fear, and impulsive reactions. But we don't know if they were born with those structures being different or if trauma and life experiences kind of cause those structures to differ. And so, yeah, you can see that there's genetic as well as environmental components to the disorder. Some of the treatment goals include obviously a reduction in symptoms, especially ones that are causing, significant disability in one's life, because it can cause major disability because people can be so impulsive and engage in risky behavior, which can either lead them to hurting themselves or actually be more likely to be a part of the criminal justice system and committing crimes. Even though the ultimate goal is remission, research shows that people diagnosed with BPD have a poor prognosis, so it's hard for them to be totally in remission. During treatment, it can be expected that acute symptoms such as self-harm, suicidal threats, or attempts, and impulsive behaviors often decrease with time. However, effective symptoms like chronic dysphoria, emptiness, anger, and abandonment still remain. So treatment is focused on getting those big life-threatening symptoms at bay, and then, kind of, because those would cause disability, and then kind of trying to figure out how to deal with those other ones. So the most realistic goal is to help the client feel empowered and recognize that their diagnosis is just one part of their identity. So again, just trying to help them function in life and really see maybe their strengths. And as social workers, that's where we can come in to highlight the client's strengths, no matter what the diagnosis is, and really help them complete their goals and live a way of life that they want to live. But it can be tricky just because due to the symptoms and just the nature of the disorder, people with BPD don't keep up with their treatment or always make true internal change. As for medication therapy, there's currently no approved medication treatment for BPD, which also makes it really hard to treat. However, just because there's no specific treatment approved doesn't mean medications aren't prescribed. Various medications are actually prescribed, such as anti-anxiety, antipsychotics, and antidepressants for emergency or long-term use. And again, that could be due to the fact that there is such high comorbidity that it still can help reduce other symptoms so you could focus on the healing. Antidepressants have little effect on the aggressive and impulsive nature, but they help decrease anxiety, depression, and potentially affect lability. Antipsychotics are able to aid with impulsive and psychotic symptoms, but then they don't help with the attachment security. So we can see that these can help, but they're not really dealing with the root of the problem all the time. So they're kind of band-aids for emergency situations. Other medications include benzodiazepines, which aren't encouraged because of the risk of increasing suicidality and impulsivity. One study shows promising findings when taking a low dose of, I don't know how to say this, quetiapine, I don't know, which is also an antipsychotic. But there's not enough research to start prescribing it as a sole treatment. But it's interesting, and it's hopefully something that could happen. And then, so our first treatment, due to there not being a prominent medication that's recommended, psychotherapies really are the main line of defense for treating borderline personality disorder and completing some of those goals, which is reduction of symptoms and really making that person feel empowered and like they can live their life. So a really interesting therapy is called dialectical behavioral therapy. And this one's really interesting because it was created by Marcia Linehan, who is a psychologist who developed it, and she's also diagnosed with BPD. So it's really interesting from her perspective, and it is a popular therapy that has shown to have actual results. It's a blend of behavioral and cognitive therapy with an emphasis on mindfulness techniques. So the mindfulness is really interesting. We don't see that a lot as such a focus. It really is a big focus. And the mindfulness is implemented to help clients with symptoms of anger management, impulse control, and emotional regulation, since mindfulness really focuses on like being in the present and living in the moment. Dialectical behavioral therapy includes group and individual sessions. Some of the other focuses include reducing self-harm, reducing behaviors that jeopardize therapy success, reducing behaviors that affect overall well-being, and increasing positive behavior techniques, like we mentioned, like mindfulness. Through this therapy, therapists strive to help the client develop new skills and modify just really reactive behaviors to appropriately fit skills in other social situations. Dialectical behavioral therapy can also be used for other disorders that have impulse control issues like ADHD, substance abuse, and OCD. So this is just an example of an intervention that could be used in dialectical behavioral therapy. So these are handouts that maybe could be given in a group, or it could be given as like one-on-one homework. The one on the left, what is mindfulness? This is really just explaining what is mindfulness, what are the benefits, and then different ways to do it. So when you search dialectical behavioral therapy, this does come up, just really highlighting how big the mindfulness component is, because I know we see it in like CBT, but it really is such a big part of dialectical behavioral therapy. So it gives different suggestions like mindfulness meditation, mindfulness walk, body scan, or 5 senses. So these are all different things that a therapist could practice with the client and then hopefully, give them homework to do outside of it. And then on the right, this is called the Wise Mind. And this is kind of more specific to borderline personality disorder and I guess impulse, just because it's really like bringing back maybe their impulse reaction to their reasonable reaction and just finding what's the best reaction for this situation. It's really breaking it down versus maybe their first instinct would be to react in kind of a big way, which results in them, hurting interpersonal relations. So I think this is a cool visual and a way to really break it down. So they can, maybe respond differently in the future and kind of start building these skills. So now I am going to turn it over to Sierra. But thank you for listening.
Another treatment for BPD is mentalization-based therapy. Mentalization in itself is the ability to focus on and differentiate between your own emotional state of mind and that of others, and to understand how one's mental state influences behavior. This happens to be limited in those diagnosed with BPD. So treatment really focuses on enhancing their ability to mentalize and improve emotional regulation. This type of therapy derived from both traditional psychoanalytic concepts and new discoveries from attachment and social cognition research. It blends both individual and group therapy to facilitate much of the psychoeducation. Research shows that this has been most efficient in reducing suicide rates than any of the other treatments recommended for BPD. And as well, it also helps the client in the long run become more independent for a longer period of time by not needing to feel reliant upon outpatient care in comparison to other treatments. The main mechanism for change in this is the establishment of a therapeutic attachment in which the mental state of self and others are explored. So this chart kind of breaks down how mentalization-based therapy would look in a session. And it begins with first the client explaining the event, and then further going into explaining more in depth about the experience and how it affected the client in that moment, which then leads to reflection, moving on to current feelings, and then it links into the experience of therapy. So what has it been like to show us this? What can you view from the other person's perspective? That's when the interventions become involved. And then at the end, the hope is to gain an alternative perspective to the original initial event. The next treatment option is schema therapy. Schema therapy combines Gestalt principles with behavioral and cognitive therapy. This focuses on the therapist-client relationship, childhood exploration, and a longer duration of treatment compared to some of the other forms of treatment. And this treatment really works well if the client has experienced anything maybe on the ACEs scale or experienced any trauma, because from there the therapist is able to explore how that abandonment, how the abandonment plays into the attachment issues that many clients with BPD display. The 5 different categories of the self, which is the abandoned and abused child, the angry and impulsive child, the detached protector, the punitive parent, and the healthy adult. They recognize these modes to replace maladaptive behaviors with adaptive ones, and learning how to readjust their schemas that they've already developed and that they place on others when making new relationships. This short video will provide some more information on schema therapy and its application. Next is transference-focused therapy, and this type of therapy was created specifically to treat personality disorders. It helps clients see the difficulties in their psychological structure in the image of themselves and in others in their lives that they have internalized, and help them to recognize cognitive distortions. This type of therapy is based on the idea that the patient experiences and lives out the internal images that make up their psychological structure in his or her relationship with the therapist, known as transference. So this is really cool because the hope is that what the client displays to others outside of the therapy office will slowly be shown to the therapist, and for there they can work through any transference issues. The basis of transference-focused therapy requires understanding what transference is, and transference occurs when a person redirects some of their feelings or desires for another person to an completely different person. For example, the picture talks about a parent is laughing at other people's feelings. Then the client internalizes, my therapist will laugh at my feelings, and have that expectation on the therapist, although the therapist is completely unrelated to that situation. Transference in therapy happens when a patient attaches anger, hostility, love, adoration, or any other possible feelings onto their therapist. And therapists are aware that this can happen, and this leads for a further exploration into a person's unconscious mental process. This can help them comprehend that patient's or client's actions, behaviors, and feelings. So there are many factors that can influence whether or not a client stays committed to treatment. As you can see, many of them are very intense, and they are expected to go on for long durations of time, and many of them often include individual and group therapy, so a client could easily be having to seek out services a couple times a week. So some of the environmental factors that can affect efficacy of therapy include whether or not the mental health professional has adequate training in the specific therapies and interventions. Most public funded mental health clinics do not have the funding to adequately train all of their staff in many of these specific therapies, leaving clients to seek out services elsewhere, which oftentimes might be more expensive. If the clinician has stigma and bias against people diagnosed with BPD, that could prevent them from offering their highest level of care. Even in my experience in talking about BPD with other clinicians, there is this off the bat, I've noticed, biased or frustration because they are well aware of the difficulties that are associated when treating this, when trying to treat the behaviors associated with this. Next is whether or not the patient has insight on their disorder and views reducing their symptoms as a positive thing. This is really working to break down much of those cognitive distortions and making them understand how their thoughts are influencing themselves and others. And since it's comorbid with some other disorders, those might pose challenges to clients fully understanding how it would be positive to maintain treatment. And last, if the client has reliable support networks that they can turn to. Oftentimes, clients have family members or other ones close to them in therapy as well to often deal with much of the impulsive behaviors or problematic behaviors displayed by the client. So having that support system can be really helpful. And not having that support system speaks to many of the attachment issues, which would be which could be a goal for the client and the therapist to work through. So that wraps things up for our presentation on borderline personality disorder. We thank you guys for listening in. There is still much to be explored and learned about this disorder in terms of causes and ways to treat it. But it's very obvious that it's such a challenging disorder for clients to live with. So it's worth exploring it and continuing to assess our own biases towards our clients in this diagnosis, so that they don't go without receiving the best care possible. So thank you. Have a good day. Bye-bye.